So my conference today is called Preventing Dementia, Critical Perspectives on a New Paradigm of Preparing Old Age. That looks very big as a topic, but what I want to do in these 45 minutes that I have to show you how this new idea of preventing dementia can be studied as a multidimensional project. And I hope I will be able to convince you that this kind of research is important. Oops. Um, sorry, now I lost my screen. Can you see my screen? Sorry, I have to stop it. I don't know what happened. Okay.
Parfait, on voit bien, Annette. Tu peux recommencer.
Yeah, you see it, right? But I can't.
Yes.
I can't change my slides. I don't know what happened here.
Avec.
Okay, now I say. Okay, now I have to do it manually. So you probably all know someone, your uncle, your aunt, your grandmother, your mother, who, when getting older, started to do crossword puzzles or Sudoku, or even learning a new language with the argument that I have to keep my brain busy, otherwise there's dementia looming at the future. Although this was a kind of prevention that was very uncertain, because at the same time, of course, people received all these news from Alzheimer's societies, from the media, that dementia incidence, prevalence is always increasing. So people were doing it anyway. It was something like everybody was doing, but it was a very uncertain way. In 2017, you probably all saw in the media this amazing, hopeful news that people were claiming that 1/3 of dementia cases may be preventable. And this was, paradigmatically speaking, a very surprising news. And what did this Lancet report show? They showed that 9 factors, I'm sure most of you know, that is low education, midlife, hearing loss, obesity, hypertension, depression, smoking, physical inactivity, diabetes, and social isolation are risk factors that can be controlled. And they are divided all over the life course, as you can see here. And what is astonishing is also that less education and hearing loss are actually the most important, as it seems here, although in the media you mostly see diabetes and hypertension, maybe because they are most easily treatable. And in 2020, the same group published another Lancet report, and they added 3 more risk factors: excessive alcohol consumption, traumatic brain injury, and air pollution. Of course, this did not fall from heaven. It was not something that was a surprise to many researchers, but I think for the wider public, it was a major turn in perceiving dementia prevention. It became more hopeful in the sense that people could say, well, now I can control much more my risk factors. And of course, it is merging with active aging campaigns and healthy aging, which have more or less the same risk factors. And at the bottom, I think we should talk about risk reduction and not prevention, but I will keep the name prevention because it's mostly used in the literature. So just as a certain historical overview, on the left here, you see the old way of dementia prevention, which is the brain is seen as a muscle, so use it or lose it. While today, the brain is still the king. Less education is an important risk factor. However, the brain is deeply embedded in the body. So hypertension, diabetes, etc. are also, but also in the social environments, like social isolation, for example, has become an important and much discussed risk factor. So you can see here the difference of what I call the new dementia. And there's also a lot of research is on the gut-brain connection, which is not part of this talk. It's just another connection that has become very fashionable lately. Or, I mean, if this last slide was a little bit infantile, maybe I can also say that the new dementia is opening up the cognitive paradigms, talking more in social sciences language. The cognitive paradigm is, after historian German Barrios, the insistence on that the impairment of cognition, so memory deficits, is enough to explain the whole dementia syndrome. And of course, we know now that this is not the case, that it's much more complicated. I don't want to go in all this historical stuff. I think it opened when the category BPSD, behavior and psychological symptoms of dementia, was became officially part of this dementia syndrome, where it was not only cognition, but also other symptoms that entered. You can see that in an article I published with a colleague. However, I just wanted to say that this is not, it did not fall from the heaven in 2017, but that it has a much longer history. But however, in 2017, it was the big mediatized event that people became aware there's much more to do about dementia prevention. And why did I use these chairs at the first slides? You will soon understand. It's because my argument is that we have to situate this new dementia, the dementia prevention. As we know, it is now internationally circulating and hopeful knowledge. Everybody reads about it. We have lots of articles that comes out and they're being translated in the media, etc. However, I believe that situating this will make us a more nuanced picture of what is going on, what is at stake. And situating in the social sciences means actually that you look at the context. So Chandler and Monday, who comes from communication studies, they say situatedness is the dependence of meaning or identity on the specifics of particular socio-historical, geographical, and cultural contexts, social and power relations, and philosophical and ideological frameworks, which sounds very complicated, but I think I want to show you some of these factors, how they can be studied, so that at the end we might become a more nuanced picture of dementia prevention. And who's in the social sciences, of course, knows Donna Haraway, who talked about situated knowledge, like this knowledge about prevention. And she claims that we even have a moral responsibility and even accountability toward multiple existing narratives. So it is important that we don't close our eyes to what it morally means, the impact of this new knowledge. So if we look at epidemiological studies, there was another Lancet report actually in 2019 that received much less attention and in which Livingstone from the other two was also involved. It says that close to 1 in 2 cases, so not 1 in 3 cases of dementia could be preventable, and this especially in low to middle income countries, because of course the risk factors there are much higher. So prevention, of course, has a much stronger effect. And over the last years, a huge number of studies has shown that in some richer regions of this world, dementia incidence rates, and even some speak of prevalence, which is contested, are actually declining. And there are some studies from the US, Holland, Germany, Sweden, England. So you see these are mostly richer nations. And the explanation these researchers give is that risk factors are better taken care of in these countries. For example, the Harvard School said the reasons for the decreased incidence are not really clear, although several medical interventions that influence blood pressure, cholesterol, and inflammation may have contributed. And of course, the question remains, can we really talk about national incidence rates, or should we talk about privileged groups, for example, in countries with stark social inequalities? If we think about the USA, where so many people have diabetes and hypertension, is this really true that these rates are going down? So I think this question we should keep in mind. And of course, as a result, as a very first result, we could ask, should there be more public health campaigns like, as we know them already, control your diabetes, stop smoking? And my answer would be here, yes and no, maybe more no. Why? I give you an example. There was one Dutch study, it's the PREDEVA study, which is called Prevention of Dementia by Intensive Vascular Care, which would be logical because people now say, oh, now we know about these risk factors, so we can intervene. And they evaluated the effect of 6 to 8 years of nurse-led intensive vascular care for older people. So they had 4 months visit to a practice nurse who gave individual tailored lifestyle advice, so on smoking, diet, physical activity, weight, blood pressure, and if needed, also individually tailored medication adjustment. The result of the study, overall, no preventive effect of the intervention was found, which is stunning and a big deception. However, for our argument, actually, it's a very interesting study because what the authors added is that they said the intervention seemed more beneficial in a subgroup of individuals with untreated hypertension who adhered to the intervention. That would see, okay, there were some people who were not treated. And what is the explanation for all this is actually that people in Holland have an excellent access to health, social system, and education system. And as one author said, a major impact might have been noticeable in the context of a country with a less efficient healthcare system. And I think that's a very interesting outcome, saying that actually who has a good access, and here in Quebec, where it's so much debates about access, maybe we should look more closely. So it's actually the access to the healthcare system that makes a big difference. So for the moment, we can conclude dementia prevention is first of all a deeply social, political, and even economic issue. So if good access to a well-functioning healthcare system is so important, individualizing public health campaigns will probably have a limited effect. And I think that's an important message for people in public health. Now, let me give you another example. What about internationally circulating knowledge and local translations? I published an article when I looked at the beginning at the clinical trials targeting prevention and early intervention. And if you, as you can see, and there's a much larger table in the article that you see here mentioned, you see on the US side, the knowledge translation or the target of the trial is mostly to test a drug as an intervention, while in Europe, it's mostly about lifestyle and cardiovascular risk factors. And here you see also some more examples. And for example, just to give you an example from the US, you can see the participants receive solanezumab, an antibody-based drug that aims to reduce brain amyloid beta. While the Prevent UK study, these interventions might be lifestyle changes or measures to affect the risk of an individual developing dementia. You see the argument, the knowledge translation is quite different. And of course, we can't say that is so clear cut because of course there are all these major international clinical trials. So it's not that easy, but still there is a tendency of maybe that in the US and in Europe, people get a different kind of knowledge. And we are still working on this with my colleagues in Switzerland and Germany on how is it actually being translated in the media to people over the last years. So what we can conclude from this second example is that different countries might receive a different kind of recommendation, and that would make a big impact, right? And as Peter Whitehouse, a neurologist, told me also, MCI, so mild cognitive impairment, as a condition that might develop into dementia is given much less importance in Europe when compared to the US, where it has almost been included into the dementia syndrome, and which also makes a huge difference, because if people get medicalized at a stage where it's not even certain that they will get dementia, this makes a huge difference economically, but also for people, individuals' life. I don't know enough about Canada. We are still starting to study this. Some people we interviewed said that actually Canada is between Europe and the US, so not as extreme towards early intervention and not as extreme towards medicalization as in the US. And so more interested in lifestyle changes, but I need more concrete data on this point. And of course, we have to reflect on the influence of such translation processes. So of course, we know, I don't tell you anything new, that the pharmaceutical industry in the US is much less regulated, as is also the media, which is much less restrictive and controlled as in Europe. And my third example that I want to give you is about Brazil. So when my first two examples were more on the macro factors involved in dementia prevention for understanding it, I want to go now more on the micro processes and see what does it actually mean. And we want to do that in different countries. So if you look at Brazil, you can see that the traditional risk factors that are now associated with dementia are quite high. Brazil has gone an immense increase of elderly over the last years, much, much quicker than in Europe, for example, Germany, France, where people slowly over last 100 years, the population got older. In Brazil, this happened in a very explosive way. So people are not very well prepared. Life expectancies has increased, but also you can have two neighborhoods in Rio de Janeiro where I lived for 10 years. In one neighborhood, life expectancy is 81, and in the poor neighborhood, just 100 meters apart, it's much less at 76. And of course, all these risk factors are quite high in the elderly population. So hypertension, diabetes, depression is especially high, physical inactivity. And of course, this is strongly related to education and financial means, except for obesity, which is strangely where for people with less education are not as obese as people from middle income, which probably is due to the economic transgression that they have done in the last years. Also, you can see that the prevalence of dementia has increased over the years. And interesting also, when you read older epidemiological studies about Brazil, in the beginning, people will always say, our numbers are exactly like outside of Brazil. We are the same as in the US. Well, today people say, no, Brazil is different. We have so many people who have low education. And in Brazil, the argument goes a lot about education, that they always argue now, Brazil is different from the rest. We have much more dementia. This should not be so much the case, because in Brazil, poorer people have free access to diabetes and hypertension medications. And you see here a photo from the Farmácia Popular. So it's a popular pharmacy where people can get these medications either for 90% less the price or for free. And in an interview with Christina Hoffmann from the Ministry of Health in Brazil, she said, we should not have so many cases of dementia because here diabetes and hypertension are free. But the life of these people is so difficult. So there you can see the importance of looking at the local level also of dementia prevention, because even if theoretically there should be much less dementia, what happens in reality that it's not so easy. And when we interview geriatricians about this topic, you can see a lot of blaming of poorer people, unfortunately, but also a big understanding of what is going on socially in this country. So a female geriatric resident, for example, she said, well, there's the cultural question that people think they only have to go to the doctor when they're very ill and do not do anything before getting sick. And then when they need help, the access to healthcare is very difficult. And a male geriatrician, he said, well, they don't take these medications. Hypertension is so common. Why take this medication? Because it makes people ordinary. Hypertension is a disease of poor people. I don't want to have a disease of rich people. I want to have a disease of rich people, they say, which is, of course, not very kind to say. And another female geriatrician, she said, oh, vascular dementia in Brazil, Ave Maria. I'm sure it's worse than in any other country. In the first world, diabetes and hypertension are well controlled. We will never get there. That's very sad. And especially in the public system, it's a mess. It's difficult to have access to medications, difficult to change lifestyle, difficult to change the diet and all that. And the access to healthcare is difficult because of all these patients have more ischemic events, microangiopathies, and so rates of mixed dementia and the vascular one are very high. In Ceilândia, which is a very poor neighborhood outside of Brasilia, people are unable to buy certain medication. If I decide to prescribe one they get for free, it will likely be an old medication with heavy side effects. It's heartbreaking. Sometimes families can buy one medication, but not another. So even if they have theoretical free access to certain medications, in reality, it's a very bureaucratic process and people have a lot of difficulty. Sometimes it's only available in one pharmacy, so they have to travel and they don't have public transport, etc. So it's not as easy as it should be theoretically. There's another study of my colleague Cynthia Engel, who was actually my doctoral student in Brazil, and she went even more on the micro level. So she went she accompanied families who were caring for someone with dementia, and she shadowed them. So she followed them to understand all the different obstacles and all the difficulties they had and all the negotiations they had to do also to either get the medication, to get a doctor's appointment, to get the transportation, to pay the bills, who stays at home. I mean, we all know this from the famous caregiver burden, but in Brazil, of course, obstacles are much, much higher than they are here in Canada, obviously. So she wrote her doctoral thesis about these micro paths of running behind good care, and it was very revealing to see actually how this globally circulating knowledge about dementia prevention and dementia care actually are lived in everyday life in Brazil. Another example in Brazil is a study we just started, is about these public sports places that you see in the middle. The middle picture I took in Rio de Janeiro. It is a nationwide initiative that costs millions of dollars, and that was implanted from north to south, and where you can all see these kind of exercise, how do you say this? It's kind of exercise people can do. In this sign here above, you can see that it's a special place for third age, so for older people. And as you can see as well, it is empty. However, when you go to Copacabana Beach, where you see older people exercising, or you see here a group, there were two reasons people gave why. At the beginning, these public spaces here that were implanted actually by a corrupt politician who I think today is in prison, was that at the beginning there was someone who was giving classes. So older people were coming and meeting, and they were a group which is highly important in Brazil to socialize. So people coming at special times, and they were having classes, and they had fun together. And then the funding was missing, so people had to do individual exercise. And as you can see, as a result, it is empty. However, here's the Copacabana beach. You can see it's much thicker. These are, of course, privileged people also. So exercising is much more interesting as a place. It is much more connected to leisure than pure exercise. And on the right, you see again groups of older people who have an instructor and who exercise in group, and it seems to be a big success. And if you walk in the morning at the beach in Rio de Janeiro, you can see lots of older people groups, especially generally with an advertisement of an insurance group or a hospital group that is financing these groups, and they are exercising. So just to show you how important it is in public health campaigns to look also at the local context. So here in Brazil, for example, to provide a group setting or to make it attractive. And of course, these spaces here that you see in the middle are also implanted, but much less and poorer neighborhoods, and they are being used. And so we are trying to understand now who is using it, why do they use it, how often do they use it, and is there a difference between more privileged groups and less privileged groups, which is very important in Brazil, of course. So what I wanted to tell you here is that I believe that this preventive turn in dementia is a real chance, a real hope for a better old age. However, only when the complexity and the interplay of genetic, physiological, lifestyle, environmental, and political economic factors are taken into consideration. And when first of all structural factors, so access to good healthcare, food and education, and as well as clean environment, as we know now from the 2020 report, are guaranteed for all. That sounds a little bit like utopia, but I think it's important to keep in mind. We also have to study translations of these findings, and they need to be carefully monitored, for example, by looking at interest groups and situated differences between groups and nations at both macro and micro levels of doing prevention. And that's what we are doing now by a research that we just got funded, which will be in Canada, Switzerland, and Germany. So 3 richer countries. So we can't say that only that differences are cultural, what would be easy to do when we compare Canada to Brazil, for example. When we look at 3 richer countries and still find differences, for example, in Germany, the medication centeredness of US knowledge translation is much less, much more questioned. So you can see that also in richer countries, there are local differences. And my colleague from Germany, she's also looking at situated bioethics, so how ethical principles mean different things in different environments. And later we will add also Brazil and eventually Israel. And I don't want to stop without my favorite quote that comes from Sir James Crichton Browne in 1905 that we found in one of the first journals of prevention. And he says, Americans break down at an earlier age than Europeans, especially from nervous ailments. And he's referring to Dr. Hamilton, his colleague, he attributes this to their struggles for the rapid accumulation of wealth, to the competition and ambition, which are largely stimulated by agitation on newspapers, to hustling, overeating, insufficient exercise, and luxurious living general. So, conclusion, it's actually not so new what we are now propagating as the new dementia. Thank you very much for your attention, and I look forward to your questions.